All right, good morning, everybody. Thank you all for being here this morning, and thanks for the opportunity to talk. I'm going to be talking about robotics and spine surgery. I don't have any disclosures. We're going to go over a little bit of a brief history of robotics and spine surgery, what the robot actually does, and why do we even need this technology. And when we get to that part, I'm going to gloss over kind of all the sort of like academic reasons why we study this technology and why it's shown to be beneficial. And I'm going to focus a little bit more on kind of my own personal practical reasons of why I use it, why I think it's a good technology. And then we'll have time for questions. Now, when I was a medical student about 12 years ago and I heard that there were robots doing spine surgery, I literally thought I was going to see one of these things in an operating room, cutting into people and doing surgery. That is very far from what the robot is that we use in spine surgery. This was the first robot that was approved by the FDA in 2004. It was called the Spine Assist, and you can see that it's very different from what you might think of when you're thinking about a robot. And essentially, all this thing is it's a tube that guides our instruments and our implants into the patient's anatomy where we want it to go. And a lot has changed in terms of how the robots work, but ultimately, today, that's still what it is. It's just a tube that guides our instruments and our implants to where we want them to go. The next advancement was in 2011, and then really over the past kind of like 10 years or so, there's been kind of an explosion in this technology of all these different robotic platforms that are used. What you can see is they all sort of share similar components. There's some kind of screen, there's a camera that's attached to a tower, and then there's some kind of device that's holding what we call the end effector, or the tube that we're going to use to put our instruments through. And then what it actually does, in order to talk about that, you have to understand a little bit about one of the most common surgeries that we perform in spine surgery, which is called a spinal fusion. We perform a spinal fusion typically when there is some kind of instability in the spine. We put screws and rods in to stabilize the spine and to try to get two bones to basically grow together into a single solid bone to create stability. Now, when the patient comes and sees us, they can have instability as part of the problem where they need a fusion. Or if we need to do something to treat a problem that they're coming in for, sometimes we have to destabilize the spine in order to treat that problem, and therefore they need a fusion included in the procedure. But ultimately, when we do a fusion, we have to put screws in to this part of their anatomy called the pedicle, which connects the back of the spine to the front of the spine. There's a lot of different ways that we can put screws into the spine. One of the ways that we do it is called the traditional open freehand technique, which means we don't use any x-rays. We use our knowledge of the patient's anatomy, and we and their anatomic landmarks to put the screw in. Down here, this is kind of what we're looking at in the operating room. This is the patient's spine looking at it from the back. And we just know that the pedicle is right here. And that's just based on our knowledge of the anatomy. And so that's typically the way that we do it when we're doing an open surgery, which is this is what it looks like. These are all the screws, these little dots here connected by a rod. Now, if you do this in a minimally invasive manner, which now spine surgery involves a lot of minimally invasive techniques, you can't use the patient's anatomic landmarks because you're doing it through the skin and you can't see them. So you need some kind of image guidance, and typically that was done with x-rays in the operating room. So what the robot essentially does is it has two things that it provides for us. It provides image guidance and it provides physical guidance. The image guidance is done by taking a CAT scan of the patient either preoperatively or in the operating room, and it reconstructs their anatomy, and we can literally take our screws and our implants and plan them and put them exactly where we want them. They have these little arrows that you can tap on the screen, changes the angle of the screw. There's a little drop-down menu here. You can select the diameter of the screw, the length of the screw, so you can put it exactly where you want it to be. You can make it however big or small or long or short that you want it, so that's going to be in a safe and effective place. And then the physical guidance, and this is literally all it does, is it puts a tube in the trajectory where that screw is supposed to go so that we can put it in the right place. And that's essentially what the robot does. So why do we need this thing? And again, these are sort of all the academic reasons of why this robot has been studied It's accurate. It's about 1% more accurate than when compared to a surgeon doing it in the open freehand technique. So it's accurate. It's safe. The complication rates from putting robotic screws in is about equivalent to doing it open. Slightly fewer chances of needing to revise a screw. The outcomes are, in the long term, like a year out, basically the same. The short-term outcomes are slightly better, but that's when really comparing minimally invasive surgery to open surgery, and the robot is generally used in a minimally invasive application. And so there's less pain, there's shorter hospital stay, patients usually get back to work a little bit quicker. And then one of the big things when comparing it to doing minimally invasive techniques with x-rays is that there's a lot less radiation exposure to the patient, the surgeon, and the operating room staff. Now, some of the reasons that I think that it's beneficial is that it enhances minimally invasive spine surgery. As we've heard from some of our fracture talks, that when we're trying to get bones to heal together, whether it's a fracture or a fusion, we're trying to get the bones to heal to one another. And to do that, they need to be stable. If they're moving around, they're not going to heal. And so that's why we need to put the screws and rods in when we're doing a fusion. And when you're using the robot, you can get really big, long screws in, which makes a much more stable construct. And this is a patient that I did using the robot. It's very subtle, but you can see that the screw diameters are all different sizes, even at the same level, at the same bone. They're different sizes from side to side. The reason for that is I'm going to use the biggest, largest diameter and longest screw that I can safely put in so that I can have a stable construct that's not going to move and that's going to support a fusion. And if you're doing this with an x-ray, you just can't do that. You can't select a screw that's going to end up maximally filling the pedicle how you want it to. So that's one of the ways that I think it enhances minimally invasive spine surgery. Another way is that it allows for additional approaches. All the x-rays that I've just shown were procedures that were done from the back. One of the other ways that we commonly do a spine fusion is from the side. It's called a lateral interbody fusion, where the patient is laying on their side. What we used to do is we would put an interbody device or something called a cage in between their bones when they're laying on their side. And then we would take all the drapes down, we'd flip them onto their belly, and then we'd put our screws in from the back. That takes a lot of time, and so one of the things we can do is we can put our screws in while they're laying on their side. This can be done without a robot. It's just technically very challenging to do that with the patient in the lateral position. And so when you're using the robot, this patient is on their side, and this surgeon is putting a screw in through the robot. You can see it's like you don't even have to think about it. The robot just has the arm there, and it's just guiding the screw exactly where it needs to go. And so it just makes it very simple to do this while the patient's on their side. When it comes to challenging cases, I think it's safer. So this is a CAT scan of the patient's bone, looking at it in what we call an axial cut. And this is where a screw needs to go. This pedicle is 2 millimeters wide. This is the spinal cord right here. This is the aorta, and these are the lungs. And so the margin for error is we're millimeters, right? And so when you have difficult anatomy, using a robot can make it very safe to get screws where you want them to go. This patient on the right is what's called a spondyloptosis, which is basically the most extreme version of what you just heard about, which was spondylolisthesis, where this bone has essentially fallen off of the pedicle. And you could just imagine that it would be very challenging to put screws into that bone because the anatomy is going to look nothing like normal anatomy, and so it's going to be very difficult to do. So I think it could be it can make these cases easier but also safer. And then lastly is that it reduces, I think, mental burden. Spine surgery is hard, it's stressful, and using the robot when it's working appropriately, it's almost mindless. You don't even have to really think about it. You just put the screws in and they end up where you want them. And yes, I'm over-exaggerating, you still have to be paying attention and being careful and all that. But it's so simple when it works. And there are studies that are being done about this and how it affects mental fatigue and burnout and all that stuff. So those are kind of the main reasons why I think it's beneficial and why I use it in my practice. And that's all I've got, so thank you all very much.